Welcome. I am very happy to be here. Um, it's a beautiful area, and it's nice to speak on the day after the opening reception. I've given a talk at 8 a.m. after club night, and we could sit at a table, literally, and discuss things. So this is a treat. So my name is Tonya White. I'm from the National Institute of Mental Health. I have no disclosures. All funding is from the intramural program of the NIMH. I do acknowledge the traditional custodians of the land on which we meet today. I'm a guest in this country, the Turrbal and Yagera peoples, and pay my respects to their elders, past and present. So it was during COVID that when I don't know if you were like this, confined to your small spaces, and this paper came out, which was "Dump the Dimorphism: Comprehensive Synthesis of Human Brain Studies Reveal Few Male-Female Differences Beyond Size." Now, we've heard talks looking at Alzheimer's, menopause, sleep, substance abuse, showing difference. So this was really interesting. And around the same time, or right around the same time, there were also papers, such as from Vince Calhoun's group, Bai, showing machine learning algorithms that predicted sex by structural MRI upwards of 97%. Another one, they also had a subgroup of typically healthy controls as well, around 98%. This study also was upwards of 95%, and then Camille Michelle Williams, I know Roberto Toro and Frank Ramus, they wrote a rebuttal against the Dump the Dimorphism study. So one of the things I'm going to do is take a closer look at this. This is kind of paving the way for this talk. The one thing I should say about the machine learning algorithms, that when some of the groups applied it to different data, they found that it did drop some, like down to 86%, but it was still much higher than chance. So with that framework, I'm going to talk about the relevance of why it's important to talk about sex differences. What is dimorphism? I'm going to go over an overview, but not deep, because there's a really deep literature of sex differences in structural MRI. I'm going to talk about factors associated with prediction. And depending on time, because I want there to be time for questions, I'm going to talk about a simulation study we did on MRI to find out if our colleagues model sex differences is what you would expect. So there are different rates of psychiatric disorders between the sexes. I study currently ADHD and autism. So autism is about 3.8 to 1 ratio, boys to girls. And then starting around puberty, major depressive disorder has a 2 to 1 ratio, girls to boys. Other factors, so I'm involved in a study. So I moved 3 years ago to the NIH. Before that, I was head of the pediatric population neuroimaging program at Erasmus University in the Netherlands. And we had some studies, epidemiological studies, looking at the role of phthalates and bisphenols, which are endocrine modulators, and trying to ask the question is if prenatal exposure to these environmental, I'll call them toxins, but have an influence on brain development. I do that together with Akgar Gasabian at NYU and my colleagues at the Erasmus. And if you know that endocrine modulators during pregnancy might have an effect, then you want to be able to know what the different characteristics of brain differences between males and females. Okay, coming back to this, so what is a dimorphism? And their comment was the human brain is not sexually dimorphic. So let's walk through this. So Most people, when they think of dimorphism, think about like you have antlers on male deer and without antlers on doe, but nature is very interesting because sometimes you get doe from Sound of Music, doe, a deer, a female deer, also have antlers. That can occur. Or growing up in the Midwest, we often saw cardinals, and the red cardinal is male and the grayish cardinal is female, but you can also see variations in animal behavior, animal, phenotype. So when you look at how much does a difference need to be for it to be dimorphism? So here we have height between males and females. Here we have gender identity, identification with male gender, interest in sexual partners. So these two are really quite distinct. Gender role behavior, but then interest in toys is overlapping, very much like height. So when you look at the brain, they tend to overlap a tremendous amount. So there's not one area of the brain that's really dimorphic. And I said I wasn't going to go in depth in these, but these are the relatively consistent findings found on structural MRI. So males typically have larger brains, but when you control for intracranial volume, then females have greater gray matter volume. The insula tends to be larger. There are also differences in subcortical volumes. The corpus callosum has been studied in both size and shape. And also gyrification has been studied, which is the forming of fissures and folds within the brain, showing differences in the structure of the brain. But when we go back to this paper here, which is the critique of the dimorphism paper, they looked at the UK Biobank study and looked at all the different brain phenotypes and found 620 that were statistically significant. Now, one of the things, if you're thinking about 620 different brain regions, the question I think that's important to ask is, how do they covary with each other? Because if you're going to work on prediction, and if they all covary together, because in essence, the drives that involve the brain differentiates the brain begins during prenatal life. There's an SRY gene, and then that results in mainly the testosterone that drives the formation during embryology of primary sexual organs, or the Eve effect would be the absence of testosterone. So I'm going to. So I was at the Brain Hack last week, which is great, and I had modeled something, but then Carvelis had done something that I thought, this is really. I'll just show this. So there's an E2P simulator, which is translating effect size into predictive utility here. So you can enter a certain Cohen's d. So for example, here, if you get, and it gives you an ROC. So if you want a prediction rate of one variable here, the ROC of 0.97, for example, then here's what the distribution looks like. But if you go down here, which is a Mahalanobis D calculator, you can set a value here. And then what I want to show you is how this changed. This is the collinearity among predictors. And so if you go, obviously, if they're all collinear, then it's just like having one effective variable. But if you move it the other direction here, if you're trying prediction here, then, I mean, here is 0.05 collinearity between predictors, and you're still way down. But if they're independent variables, then you really can make use of it. So that's why I asked the question of these 620 variables. I don't know the answer, but I'm curious. How do they covary? So let me go back to the slideshow. So now I'm going to show you one of the things I did during COVID, and then I eventually completed with some of my intramural research training fellows at the NIH. So we were able to get a hold of 147,931 individuals from 41 independent studies. Beginning in ultrasound with head circumference, about 36,000 between 13 and 40 weeks. These are from different studies. The head circumference data that we have is from growth charts from the World Health Organization, from the CDC, and from the Chinese growth chart. And then from Sophia Frangu, we were able to get a hold of about 85,000 between 3 and 89 years of age, and Enigma lifespan. And just asking one question, and that is this: when do differences emerge in global brain measures in the brain? And what is their, I'll call it trajectory, but you may critique me for that because there are different studies and some cross-sectional, some longitudinal. So, but it's the lifespan differences. So let's start with prenatal life. Here are four different studies, and do I have a pointer? What I can show you is that, here we go, there we go. That differences begin as early as 10 weeks. And there may be a peak. So some of the studies tended to smooth their data, so it's unclear, but there may be a peak at around 25 weeks. What we do see from the head growth, head circumference data, is that there is a definite peak at 10 weeks here. Where, okay, so sorry, I should go back and explain this. This is Cohen's D, and this is males greater than females. So, so when we go back, sorry about that. So males greater than females, here's the effect size difference here. And so males greater than females up to about 1.1 at about 10 months of age. Then it drops down up until, you guessed it from Hayoung's talk, puberty takes hold and the emergency alert goes. So this is cortical thickness below. I'll talk about it next. So here we have surface area. This is from the Enigma study, cortical thickness and cortical volume and ICV. So you see that there's an increase up till around maybe 25, 28 in differences in effect size. And then it plateaus. And cortical thickness is actually bigger, larger in females, but then it becomes even during adolescence. So if you put all these together in a logarithmic graph, age is logarithmically associated. Many developmental people do it because we're focused on this area. I think aging might do the other way around. But you see really three different peaks. One potential peak here, a peak here, and then a peak associated with adolescence. And that actually corresponds with peaks. You have a peak at about between in prenatal life, around between 10 to 20 weeks or so of testosterone, you see a peak. It's called a mini puberty after birth, and then, of course, the regular puberty. And actually, those who have what's called congenital adrenal, complete androgen insensitivity syndrome do not have this pattern. They have the female pattern. So that suggests that it is related to hormones as opposed to genetic factors, because they are XY. So in the time that I've remaining, which is, I'm going to give a whirlwind view of this. So the question is, how do our colleagues do in this? So we had a consortium from different sites around the globe who, the goal was to simulate data, and the project involved, so each of the 5 groups simulated 3 data sets, each data set with 10,000 people. There were 7 waves of data. This data is freely available. And we gave them, the goal was to embed in this data how they think the interplay between brain and behavior takes place over time. So it had nothing to do with sex, but I was curious, how do they model sex? And they modeled it very differently. So, so the goal, actually, here's to access the data and the study design. It's preprint here, but it's been published. But the goal is to approach the data as you would for any large developmental neuroimaging data set, and it's not to identify the exact model, but just the interplay. So here are the curves of just how the different groups, the different studies modeled, gray matter volume, white matter volume, hippocampal amygdala, intracranial, and cortical thickness. And here is the same measure that I showed you before. These are effect size, males over females. And you can see there's a dramatic difference, some having some nonlinear effects, some rather fancy patterns, and some with a decrease over time, but very different than what actually took place. So in summary, sexual dimorphism or a mosaic. There are high prediction rates for machine and deep learning approaches. So there are probably features within the brain. Some behavioral features show differences between the sexes and fall into a pattern of dimorphism, but others do not. So the question is maybe the resolution of what we're looking at, if we're not yet able to detect things at the level of a dimorphism. The effect size in global brain measures between males and females is not constant over the lifespan. And so for prediction models, that's going to have a difference depending on age. And there's different groups have different assumptions regarding global and regional sex differences in the brain. So here's my group. And for this, Sam is here, Brianna is here, and Netta is here, and they did a lot of the work. So now we have time to open up the panel for questions for the last few minutes. So thank you.
We actually have one question uploaded here, so let me read the question. Okay. I don't know who asked this important question, but let me read it. Thanks for putting together a wonderful session. I appreciate how much effort is being put into looking at sex differences in this area of research, but gender is still often ignored. What can we do as a field to better understand the influences of gender on brain and behavior, especially in the current political climate? I don't know whether we have answer for that, but at least we can discuss. So Tonya, why don't you, so you change it, you have to change your title a little bit because of some, like, I don't know. It's everywhere, politically, it's crazy everywhere. Even in Korea, our ex-president cut the R&D budget more than, it's various for individual but R&D, but mine was cut about half.
I could try and answer the question on gender that was asked. So when you look at sex and gender, there's a lot of overlap it depends on what you're defining as gender. So there's gender identity, and then there's gendered life experiences. And a lot of gendered life experiences you could get at by looking at social and structural determinants of health, because often the social and structural determinants of health that are negatively impacting health, unfortunately, weigh also on female sex and women as a gender. And so I think looking at social and structural determinants of health can help us look at gender as a variable. But we have to be careful when we do this work, because gender identity, sexual preference, and gendered life experiences are three distinct phenomena, and we shouldn't mix those three things together.
Differences that happen throughout the lifespan up to menopause. So if you had any kind of commentary on neurodevelopmental and like estrogen and progesterone.
Yes, so I think the data shows that estrogen exposure is neuroprotective and supports neuroplasticity in the brain as we age. And that's a very good question. In our data set, we do collect data on menarche reproductive exposure, oral contraceptive use, HRT use. One of my students, that's one of their projects right now, is to calculate estrogen exposure across prior to menopause and see if that is also a predictive factor on how current estrogen levels affect brain aging. So unfortunately, with this study, we used ELISA at the beginning to look at estrogen levels for confirmation of menopause status. ELISA, you cannot detect estrogen levels after postmenopause using ELISA because it's below the detectable threshold. We are now in the Toronto site using mass spec, so we should be starting to collect estrogen levels in our postmenopausal females moving forward. But we can look at estrogen levels in our pre, peri, and young adults, obviously.
I guess a follow-up question would then be thinking about artificial hormones and birth control and how that's going to, like if you take a cohort of women that are menopausal, those who haven't been on hormone birth control, and those who have, and whether or not, the differences in the slopes of the
So it's so when we do measure all of these things and we can account for that. It's important to keep in mind that one of our variables of interest is vascular risk factor, and one of the contraindications for these kind of hormonal replacement birth control is having poor vascular health and risk for stroke. So we might not be capturing everything when it comes to vascular risk when we look at this variable, because if you do have poor heart health or brain health, you're not going to be recommended to go on these things by your doctor, or you shouldn't be, because it puts you at risk for stroke and heart attack.
Right. When we talk about the hormonal effects, we should be very careful because there are many hormones, right? For example, estrogen is not always good. Sometimes estrogen can trigger seizure aggravation in some of the epilepsy patients if they have a catamenial tendency. And also estrogen can be, the hormonal pills, birth pills can be a risk factors for the venous thrombosis. It can be a direct risk to increase that risk. So, the ratio between estrogen and progesterone can be some effects. And progesterone is believed to be neuroprotective in some, aspects. But you should be very careful, and you should be very specific on what kind of effects on that neurons.
And I would say it's also very important as we go into looking at intersectionality, because different communities have different risk factors for these things as well. And so you have to, if you cannot make recommendations or generalizable analyses in these areas.
Yeah. And I think, is it dimorphic or mosaic? Is that for, I think that's for Tonya's. Is it dimorphic or mosaic? Can it be more specific?
I think the case is still out. I think there are elements that are clearly dimorphic, but they're certainly mosaic. And I think of the brain as if you think of other organs, there's many of the functions that are exactly the same in everyone, right? The cell functions, the potassium channels, all these different things. There might be slight differences, but there's slight differences, but there are differences in certain areas, and those areas it is dimorphic. So I just think we don't have the resolution yet. I think there is an element of dimorphism in the brain, but a lot of it is a mosaic. So I'm going to say it's both.
And you mentioned that global brain size differences between sexes may be driven more by hormonal influences during development than by genetic factors. I found that particularly interesting. Is there potential interactions between genetic variations and hormonal effects? Is that for you or you?
Genetic variations.
Genetic variations, and you can actually see you. So hormonal influences during development, then genetic factors. Do you think it's more like hormonal? Because you
So
showed us.
it's driven at the beginning by genetics, but then the influence from there. There are individuals with disorders of sexual development who have, so for example, the complete androgen insensitivity syndrome, that they follow a female pattern of brain development that suggests that it's not just the XY chromosomes, although there could be some differences in other areas, epigenetics and the autosomes of the,
Okay, so one quick question. So Natasha, episodic memory performance needs adequate sleep and mood. How did you evaluate sleep prior to MRI? And what about effects of HRT?
So, we're not a sleep lab, so we can't do everything, but we do have the PSQ on our participants. So we have like the quality of sleep measure. That's about it. That is an area that needs to be improved, and if there's anyone that wants to collaborate in that area, I'm happy to. It's just you can't do everything. And then the other question was on
the effects of HRT.
HRT.
Prior to MRI, do
Prior
you
to-
have specific instruction? Don't take any pill.
No, we don't have any of that. We are trying to do a representative study. So at this moment, we don't. We just opened our inclusion for HRT use. We were excluding females that were on HRT. We were including females that were on oral contraceptives if they were using it for reproductive protection, but not as a supplement to HRT. So it really depended on the age and their answer to why they were on oral contraceptives if they were included in our study. But for HRT use, now we've opened up HRT use because it's a sub-study that one of my students is interested in. We're particularly interested in HRT adherence across different communities because HRT, it's not a magic pill. HRT really has side effects as well, and it's whether or not you could, whether it's with every medication, it's side effects versus benefits, right? And whether or not females, what are their side effects and whether they adhere to the use of HRT, and then how does it relate to cognition and brain health? So it's more complex than just, are you on HRT or not?
Do you have any questions?
Yeah, sort of a question and a comment for, I think, primarily for Natasha. So I was just watching your talk, thinking about lifespan and hormones and menopause, and of course in males it's a slow, steady decline of testosterone function time. But there are other groups out there, and I was wondering if you, with large studies like yours, you might have them in there. Now, intersex, which is what Tonya was mentioning a moment ago, that's 1 in 1,500, so you're not going to have very many of those. But males who are undergoing, especially prostate cancer, which is one of the most common forms of cancer, usually have very strong androgen inhibitors, and therefore they go through, their testosterone usually is zero, and that's kept there, right, for the prostate cancer. Do you have any of those, or have you thought about looking at those in your data set?
I have not. This has
Okay.
been really a study focused on menopause and
Okay.
menopause transition.
Yeah.
We go up to the age of 65. So a lot of times we might not have, we do include males in our study, more as a age control match kind
Right.
of, and to look
Yeah.
at, we do measure testosterone and all these things in males, but if they are
Okay.
currently having treatment for prostate cancer, they would be excluded from our study. But
Right,
it's a
okay.
very important question.
Yeah.
Yeah, it is a very interesting question to how males age as they undergo these treatments and also as their testosterone declines. Usually in the early 80s, late 70s, early 80s is the natural decline in males. Yeah.
Right. Yeah.
So thank you very much, everyone, for coming to this session. As I said, it's really nice to have a large group and enjoy the conference.
Thank you.